Talk to me about the burden associated with SLE. The typical clinical sequelae of the disorder, morbidity, mortality of suboptimally managed SLE, if you can actually make the diagnosis in the first place.
Well, early diagnosis is key because we do have a preventive therapy for lupus, which is the anti-malarial hydroxychloroquine. And as with any disease, education matters. And I think in Europe they're a little ahead of us on looking at adherence. It turns out that probably as many as 40% of patients with lupus aren't taking their anti-malarial therapy regularly, even though we teach and we know that using hydroxychloroquine can reduce flares, reduce lupus nephritis, reduce thrombosis, and in 2 different studies it improves survival.
Survival, key.
Well, yes, because there is still a 10% mortality 10 years into the disease. Now, this is an improvement, of course, because back in the 1950s, half the people with lupus died in the first 5 years. We've turned a fatal disease into a chronic disease, but a chronic disease with substantial morbidity, with actually the major cause of death being cardiovascular disease.
Is that right?
You know, what a surprise. Inflammation matters in the coronary arteries.
So, at what stage of this disease do you typically see patients presenting across the board?
The most common presentations are the photosensitive rashes or arthritis. And the arthritis will look very similar to rheumatoid arthritis initially. But what's different about lupus is that it's not just limited to one organ, and that patient who starts with skin or joint may develop lupus nephritis in the future, low blood counts, but in addition, lupus can be life-threatening in its manifestations in the central nervous system, the heart, the lungs, the gastrointestinal tract. So it's sort of a shifting target. You can never feel that lupus has done its worst. It can still keep on giving.
I've got to say it, it's the disease that keeps on giving. Is that what you're saying?
Yes.
And what that does imply to me is that the quality of life issue is real. I mean, sometimes they go for a long time without a flare, and then they have...
This is an unpredictable disease. As somewhat like MS, it can have this relapsing remitting pattern where the woman doesn't know when she wakes up the next morning what is her health going to be. I guess it won't surprise anyone here that 1 out of 3 women with lupus go on to disability. The quality of life of a woman with lupus is equivalent to full-blown AIDS or 3-vessel coronary artery disease. So yes, these are lives of misery.
I don't want you to just let that one slide by. I want to come back and just mention that again. Full-blown SLE, the quality of life issues are like full-blown AIDS or cardiovascular disease, 2-vessel, 3-vessel disease.
Absolutely. So it's not surprising that these patients often go on to disability with our current standard of care.